is Winona Burks, and I will be your instructor for Mental Health Part 3, continued. So we're going to talk about eating disorders. A common theme that I have noticed about eating disorders is that in one way or another, food is equated to some sort of control. Why do we care about eating disorders? 160 million Americans are obese or overweight. Your book indicates 69% of American adults are overweight. Anorexia nervosa, they can become medically unstable. Bulimia, they can become medically unstable. Eating disorders, it's linked with cardiovascular disease and diabetes. Otherwise specified feeding or eating disorders include patients that have the symptoms of anorexia, bulimia, or binge eating, but do not meet the qualifications of a DSM-5 diagnosis. Why do we hospitalize patients for anorexia and bulimia and not binge eating or obesity? Patients with anorexia or bulimia become medically unstable. Mortality rates are higher in anorexia nervosa than in any other psychiatric disorder. Why is it important to remember that patients with eating disorders typically have comorbidities such as mood, anxiety disorders, substance abuse, and personality disorders, an increased risk of suicide? That's why. Because what happens if you have a mood disorder that is not treated? It can lead to a very negative outcome. Oh, cognitive distortion. Ways that our mind convinces us of something that isn't really true. These inaccurate thoughts are usually used to reinforce negative thinking or emotions. Telling ourselves things that sound rational and accurate, but really only serve to keep us feeling bad about ourselves. Cognitive distortions are irrational or extreme thinking. Neuroendocrine abnormalities include hypothalamic dysfunction for patients diagnosed with anorexia nervosa. Patients may have symptoms before the onset of starvation and significant weight loss. They're cold all the time. They stop having their period. They start to make excuses to not eat with the family. Neurochemical influences in bulimia have been associated with decreased serotonin and norepinephrine. Low levels of serotonin may play a role in compulsive eating. Weight loss, dehydration, bradycardia, and hypotension bring them in the hospital. The risk of death keeps them there. They have a risk for refeeding syndrome. I read a study that was conducted and published by several dietitians that were researching mortality and refeeding syndrome. The body's intolerance to nutrition can result in cardiac failure, life-threatening hypotension, pre-renal failure, and sudden death. Anorexia nervosa is one of the more common modern clinical presentations of refeeding syndrome, according to Cook. Also, Cook states that the administration of calories should be given slowly, particularly during the first week at about 20 calories per kilo of the body's weight per day. And we weigh the patients every day. So as they gain weight, we need to adjust their calories. Therefore, nutrition support may be needed so that they can modify the patient's caloric intake. And that is in relation with the patient's clinical condition or their weight gain. So what do you think about the family providing outside food? Do nurses have the time and resources to recalculate the patient's caloric needs to incorporate an outside meal? And would the nurse be held responsible if the patient experienced refeeding syndrome after they asked the doctor for an order to allow for an outside meal for the patient? Excessive weight loss can cause shrinkage of the brain's gray matter. A study published in May of 2010 issue of International Journal of Eating Disorders showed reduced brain volume in people with anorexia nervosa. When anorexics starve themselves to lose weight, their brain starts metabolizing its own gray matter. However, those subjects who regained weight also regained brain volume. How does the loss of brain tissue impact the nurse's ability to care for a patient with an eating disorder? So, reduced brain volume. The gray matter that's affected, you can see in this picture, is the frontal lobe. So that's going to affect cognition and processing. So you have to try to convince someone that they have a huge problem when they are not able to use their cognition at full capacity. It makes things a little tricky. Core concept, body image. For anorexia nervosa, we'll define that as a subjective concept of one's physical appearance based on the personal perceptions of self and the reactions of others. What do we usually say when we see someone that's lost a lot of weight? Good for you. Wow, you've lost a lot of weight. You look great. Now we're going to look at some nursing diagnoses for anorexia nervosa. Imbalanced nutrition less than body requirements, deficient fluid volume. This nursing diagnosis brings them to the hospital. Imbalanced nutrition, we want the patient to not have any signs or symptoms of extreme malnourishment or dehydration. Disturbed body image. This is a very important diagnosis because remember, they have that cognitive distortion. They do not see someone who is starving, and they do not want to gain weight. So, watching television with commercials of skinny people, magazines where they talk about food or really thin models, or even the way you communicate with them when they're eating a meal, when you say, "Good job," you're basically telling them that they are getting fat. So we really have to watch our language because remember that gray matter has shrunk, right? So it's going to be hard to use language that they will be able to interpret in a positive light because they're going to have that deficient knowledge and they're going to have a hard time obtaining knowledge until they gain weight. Ineffective denial. This is all about control. They're using maladaptive eating behaviors to cope with emotional issues. This nursing diagnosis is the reason behind their behavior. We want our patients to begin to demonstrate the ability to stop using maladaptive behaviors. Most individuals with bulimia are within a normal weight range. Some are slightly underweight, some are slightly overweight. Bulimia is characterized with frequent episodes of binging and purging. 50% of individuals with bulimia nervosa have had a history of anorexia nervosa. Core concept for bulimia is excessive, insatiable appetite. Repeated episodes of vomiting and induced frequent diarrhea lead to electrolyte imbalances. The enamel on the teeth erode because of the frequent wash of gastric acid when the patient induces vomiting to purge unwanted calories. The callus formation on the patient's knuckles are the result of long-term self-induced vomiting, and it is called Russell sign. The patient with bulimia may experience subconjunctival hemorrhage as a result of frequent vomiting. Nursing diagnoses are the same as anorexia with some changes. Ineffective denial is now a lack of control. Maladaptive eating behaviors are used to cope with emotional issues. This nursing diagnosis is the reason behind the behavior. With bulimia, a sense of lack of control, overeating during the episode, feelings that one cannot stop eating or control what or how much one is eating is experienced. Comorbidities include central nervous system, stimulant, or alcohol. Binge episodes bring pleasure and then self-loathing and depressed mood. The nursing diagnosis of ineffective denial and disturbed body image and low self-esteem are the most relevant for the patient that has bulimia nervosa. The long-term goal for ineffective denial will focus on the patient's ability to discontinue the use of maladaptive eating behaviors and to cope with emotional issues in a more adaptive manner. The goal for the patient's body image and low self-esteem should focus on building up the patient's self-esteem and decreasing the patient's preoccupation with their behavior, or with their appearance, In the hospital setting, the nurse's goal is for the patient to become medically stable. There is a hereditary disposition with binge eating. Events may be linked to interpersonal stressors, low self-esteem, and boredom. These patients are not treated in the hospital for this diagnosis unless they are having a surgical intervention that affects caloric consumption. Green is up to 25%, yellow is 20 to 30%, red is greater than 35%. Has anyone ever seen a patient admitted to the hospital with a diagnosis of obesity? We would have to shut down the hospitals. It is responsible for what is killing us: diabetes, heart disease, cancer. It is the silent killer that everyone knows about, but we do not make enough money off of it to prioritize treating it. There are other eating disorders. Diabetes is one of them. Young people that have diabetes can deliberately misuse insulin to lose weight. There are subcategories to anorexia, bulimia, or binge eating disorders. Please watch the video before moving on. Eating disorders, why do we care? Up to 1/3 of the deaths related to eating disorders are due to suicide. There is a history of sexual abuse. It is more common in those with eating disorders than it is in the general population, and women with a history of eating disorders and sexual abuse have a higher rate of other comorbid psychiatric illness than any other diagnoses solely with eating disorders. How does this affect your view of a significant other that will not leave the bedside? What is your role as the nurse? What information do you want to obtain? What priority assessments will you perform? Those are the questions you need to answer as you work through this case study. Do you see any red flags here? Remember, hospitalization is necessary if the patient is medically unstable. So, what do we want? Which of these outcomes can we achieve inpatient, and which of these outcomes are going to have to be achieved outpatient? Evaluation needs to take place regularly, especially if the person with eating disorders is an inpatient and still losing weight. Success has been observed when we use a contract for privileges that is based on weight gain, and the patient has an input into the care plan, and they can clearly see what their treatment choices are. Why would these treatment modalities be effective? Because they give the patient control. If you are going to care for a patient with an eating disorder, you need to be able to answer these questions. Remember, reevaluation. It is key to making sure your nursing interventions are appropriate for the patient.